In fact, it only should include up to, what did you say, 3/4?
50%.
50%. So that probably answers whoever asked about the suctioning thing too. Is that you know, well, she's going to tell you how you can do it. There's a little trick to it.
Yeah.
But, you know, it does allow for them to get their secretions out, and particularly the CO2. I'll let her take over here.
All
Brittany's
right.
good at this.
So there are 4 sizes. So each size is color coded and has the size on here. On the back of the container, you have a little picture of the nair size. So you can use that as a guide. Like Katie said, you want 50% occlusion of the nairs. So the cannula, if you see here, it actually has like a wire on the inside of that.
Like a coil spring.
Yeah, and so that is actually coated twice with a special plastic material that's designed to help wick away moisture. So it's not a traditional plastic. It's called a Vaqua. So what's nice with this wire in there is now you can take it and it's going to be totally kink proof. So you can take it and pinch it off. I could take this, tie it up in a knot, and it's never going to kink. So that's really nice. As you come down to the nairs, or the prongs here, they are actually independent flows, so they do not meet in the middle. Okay, so if you were to remove one side or peel it back, yep, the patient is still getting some kind of therapy here, but you can actually peel that back and do any kind of cleaning or suctioning you need to. So what's nice with these with the cannulas is that there's these little pads on them called wiggle pads. So it takes the place of like dots or tape. It's a hydrocolloid material, and then it's got little Velcro on it. So it comes on there, and you can actually now just peel it back and quickly and easily replace it. Yep, so just like that. Yeah, you just kind of gently pull that back, do any kind of cleaning or suctioning you need to, and then it's pretty easy to...
And they'll be humidified, so you'd have less need to put the saline in to get the things out.
You guys still use saline?
No, when we suction with
suction,
saline, yeah.
Because sometimes their secretions are pretty
Oh,
dry.
it comes out. Are we not supposed to do that?
Well, no. I'm thinking more, you know.
We think it works well.
Yes.
With
Yes, we do.
well, if you put normal saline on a snotty thing, it does nothing. It's not a it doesn't break up mucus or anything like that.
I've been lied to.
I think it, because like now with ET tubes, you know, we don't ever put normal saline down an ET tube, never. In fact, all it does is wash down the biofilm. And it is not a mucolytic. And it can cause more infection, so we do not. But I think when they do the little here, that's that's okay. Yeah.
Okay. So let me kind of take a look here at the circuit, and you had mentioned some alarms with the temperature. One of the things to look for is just to make sure that this temperature probe is pushed in all the way. It can be a little bit difficult when it gets, you know, towards the end here or right up here. So if it's, you know, not sitting in there all the way and there's like a cold draft blowing right on that temp probe, sometimes it can drop the temperature. So you really want to push that in there. The cannula clicks into the circuit and you hear a nice secure click. There's actually a swivel at this little part right here, so you can actually twist that around. So if the cannula is tangled, without having to break the circuit, you can, you know, untangle it. The cannula is pretty flexible, so you can lay it, you know, over in the front of the patient, or you can kind of come down to the side and use this little piece to take out the slack there. The wiggle pads, you know, they're designed to last 7 days, but if they do get kind of creased or soiled or anything and you need to replace them, we do have extras, and they match the colors of the cannulas. So you have, you know, one size for these 3 here, and then one size for your preemie.
Have you seen them in ED yet? Stock?
No.
Are we
Not
gonna,
stock.
Are we
Are
gonna
they
stock them down there? No. Okay. Yeah, you guys don't have any.
No. And
Yeah, theoretically they wouldn't be down there long enough to need a replacement pad.
Yeah.
I mean, I would imagine if you're keeping a machine down there, that maybe you put a little bag with the set there on the
There's a
machine or
basket
something?
of it.
Yeah, yeah, right.
Yeah.
There's a wiggle pad. So I'm actually gonna take out a cannula and show you guys how to fit it. So when you take it out, it's already gonna come with the wiggle pad. pads on. So it's really similar to like putting a Band-Aid on. You're just gonna slide one half off. You see there's another kind of folded piece down there. So you'll just slide one half off here, one part off there, and now you have a little bit of that sticky exposed.
Right, I see.
Okay. So then you'll just come and place it in the nares, and you can stick it down right away. And then that little bed portion is still underneath, and you can just peel that out.
But realistically, it's going to, or I would never do this without a respiratory therapist.
Yeah, because they have to start it.
Yeah, so, but good to know, but just saying.
Yeah.
If we notice that their patients are desatting on there, what would be the, things that we should be checking first?
See if the prongs are in the nose.
Yeah, and should we be suctioning the prongs? Like check to make sure they're not occluded, or just check the flow, or,
Yeah, you can. Sometimes if they pop out, they can be kind of bent over to the side. It's a very soft silicone prong. It's not like your traditional hard plastic cannula.
Right.
So just make sure, they're in the nares properly. You can pass that down there too.
So we should like suction one nose at a time, like suction one, then tape it down, and then do the other one? Okay. And then before with the old plastic one, sometimes we'd pop it where the large tube meets the smaller tube, we'd pop it open and dump all the water out. Do we have to do that anymore?
Well, and the reason you would have to do that is because you get a lot of condensation or rain out in your circuit. So this circuit, if you notice, there's like this clear circuit over a blue circuit on the inside, and you can kind of move it like that, and it will kind of go over. It's actually going to act like a sleeping bag, so it's going to keep it really, really insulated. So you should see a significant decrease in having the need to have to drain it. But if you do, you don't have to break it. You can actually just kind of dump it back into the chamber, into the humidification chamber. So you can just kind of, if you come over here and just kind of, dump it back in.
should we be careful about having the tubing looping down below the level of the patient? You know what I mean?
Yeah, no, that's fine.
It's okay.
Yeah, that's okay. So, and on the circuit here, you have a clip as well. So that'll actually slide up and down the circuit. You can move that,
Oh, you clip
twist
the
it around.
sheets and
Yep,
stuff.
and then it's just like a little claw. You just squeeze it to open it up.
We have had from time to time kids play with it. You gotta watch that sometimes.
Oh,
Little
right.
ones, grab it.
What other questions?
So let's talk, I'm, maybe you guys covered this and I was not here. So, when you kick the rate up to 8 liters, does that change the percentage? I know there's a mixer there, so, it's each time you increase so what I'm gathering is each time you increase it up to like 6 or 7 or 8, you're gonna that will increase the FiO tube, is that true?
It depends.
Because you said like, if they're not doing well, you increase it up to 8, but we never go past 50%.
But remember, why are we increasing the liter flow? We're increasing the liter flow.
To blow out the trapped air.
Yeah, the CO2.
That's what I want to confirm,
so
that if I know if I'm getting that right.
If you're above, so like I said, you and I, minute ventilation on everybody on this planet is about 5 liters per minute. So if we start at 6 liters, and that's what you're going to see down there. For most of your patients, now you've met their minute ventilation, so they're not pulling in any room air. So whatever you have set on here is going to stay at that. So if you increase the increase the flow rate, the FiO2 is still going to be what's on the line.
It'll still be 50%.
Yeah, it won't
You're
up.
just removing the trapped air. You're
Yeah,
just
you're-
increasing the less chance that there's going to be
CO2, yeah.
It's a CO2.
So we're really
in
increasing
that
that.
anatomical dead space.
Yes, and then the other thing too, of course, is as you increase the flow rate, you're increasing the resistance that they're breathing against. And sometimes that is, so the more
increase
PEEP
their
you have,
more PEEP.
that can increase their saturations, because now they're not working so much and they're keeping that alveolar open so the oxygen can go back and forth. So it actually increases the flow rate. Inadvertently helps with saturation. There's not a lot of PEEP though that's created by this device. If there was, it would have to be monitored a lot closer, but there is some.
So,
Yeah.
And then my next question is, I wanted to clear up, so when we have the huddle, if a kiddo has comorbidities,
Yes.
they're not going on, is that what we're saying?
No, that's why you have the huddle. You have those things that you need to think about, is what is in the best interest of the kid. So if you had it would depend, like say if it's a cardiac kid who had a cyanotic heart defect, right? Those kids you don't want to see 100% oxygen or have any chance to see high oxygen concentration. So those kids they would probably say, no, we're not gonna go ahead. We actually had a kid not long ago that we, upstairs on the floors, it was a kid who had just come in, I think he had started in the ED. So, yeah, okay, at Summit, they started at Summit, but he had just been transferred over from the ED. And family didn't speak English, it was a language that we didn't have a lot of interpreters for. Anyways, long story short, the kid started getting worse, he was on 6 liters. They upped the FiO2 here because the kid was getting worse. They were already at 6, so they started upping this because they knew the kid was getting worse and they were waiting for our team to go over and get the kid. And once they went over 60, 70%, the kid had the reverse heart flow, flooded his lungs all out, and the kid was just a wreck coming from Summit over here. I mean, it almost killed the kid.
So do you want to go up on the liter flow before you go up on the FiO2? I mean,
Yes,
we obviously won't be doing this,
If you're at 50% already, which you should be, yes, that's what you do, go up on the liter flow.
Okay.
Or is there an indication for patients who might need a lesser oxygen concentration that you could start the flow but start the FiO2 lower?
We always,
Or no?
so that's the reason for a protocol. You always start at 50%, and then, yes, you can go down, but remember we said we don't wean in the ED.
All right,
So
I mean for a patient that has a comorbidity that would demand less
Oh,
oxygen.
yeah, you could play, yes, you could. That, if it was decided that it was the best interest of this kid, like say it was a heart kid who had a airway that they knew they couldn't intubate and that, and they just said, well, for this case, we'll, I should let you know too, we have a protocol on the floor for palliative care of kids. It's a wonderful device for kids who are at end of life and they don't have everything else on them and they go on heated eye flow up in the HEMOC. But yeah, that's an alternative.
Katie, so on that machine, I assume it's the meter on the left is the one that you're setting to 6 liters?
Yes.
And what's
this
the
one.
meter on the right?
Well,
for?
that goes up to 60 liters per minute. So this one only goes to 50. Well, I'm going to tell you for 2 reasons, but this one is for, because we use these devices all over. So this could be the ICU. The ICU sometimes goes up that high, because remember we do have, if you have a kid that comes in who is, let's just say 14 or 15, and he actually, has really bad pneumonia and qualifies, you may be using this device. That would be that you would use, there's a larger tubing, and it's actually a larger board here, and that, the adult sizes can go up to 60 liters per minute, and you'll probably see that in your time here.
Do you want one of those cannulas,
So,
baby?
yeah, you can show them what it looks like. Now, the other thing that some use this for is that, again, if you have a really, really sick kid, now you have the benefits of the blender. They actually put the flow inflating bag on here so that you can use, you don't have to use 100%, but you could use this and get the precise FiO2 if the baby had to be suddenly manually resuscitated. And that, you guys know, in the ED on the floors, we don't put those bags upstairs on the floors, the nurses don't know how to use them. Nor do the doctors.
So, I think as far as I understand, 6 liters was our maximum flow on the acute care floor, but is it?
No.
Is it changing to 8 now?
It's been an 8 for a while.
Oh, it has been 8.
Yeah, you
It's
can
on
look
the
at.
escalation side.
But then 8, after 8, they transfer to PQ, right?
Yes,
Yeah.
yes. They don't stabilize on 8. They go to, yeah. Now there's, again, our PICUs, we have limit on beds, so there's that huddle too, and sometimes they push it a little. Oh, let's keep them up there a little bit longer. Yeah, that happens. Now the other thing is, let me just tell you this, because this happened just a little while ago, so I don't know why I get involved in these things, but went into the PACU, and the physician in the ICU said, we're not ready for this kid. The kid wasn't doing good in the PACU, had just had an upper airway surgery or, I don't know what, tonsillectomy, which, we wanna do those patients well here. And then, so they put him, he says, just put him on heated high flow, just that whole thing, just put him on heated flow, getting like, albuterol treats everything, so now heated high flow treats everything. And so I knew the nurses weren't trained over there. So I went over to the PACU, and sure enough, the kid was decompensating more, and the nurses had put a non-rebreather over the heated high flow. Now, do you think that that would increase the kid's FiO2 anymore? No, it did nothing. All it did was then you were seeing water dripping down because it was, the cold air was going over. And that could have been a really bad scenario, because they thought they were doing everything they could. And then I just came in and upped the FiO2 on the blender, and they said, what'd you just do? And that's a good, so marched back over to the ICU, of course, and said, don't ever order that where nurses aren't trained. That's totally inappropriate to do that.
Was this like 2 weeks ago on a 3-month-old, little girl?
It was a little girl in the PACU.
Because I think they were, so I floated to the PQ a couple weeks ago. It was really crazy, and they were trying to give me this admission.
From the PACU?
And I'm an acute care nurse. I have no PALS or anything, skills.
Yeah.
So the manager was like, "Oh, we'll help you out." I'm like, "No way,
Yeah.
it's crazy."
Yeah, if you don't feel comfortable or confident, you shouldn't. And there's, like I said, this is not just a simple nasal cannula.
Exactly.
It's not. Yeah.
So only the RTs are supposed to change it,
Yes,
settings,
yes,
right?
yes, yeah.
Okay.
And on the floors, so it used to be the nurses were allowed to